So hello everyone. So my topic will be combination prevention. Actually, combination prevention in preventing disease is a very common approach for many diseases. A good example will be the cardiovascular disease, such as you have to practice a healthy lifestyle, healthy diet, have more exercise, and no smoking, etc., to prevent the risk of cardiovascular disease. And for certain cancer, you have to, there may be, apart from the lifestyle modification, you have the screening and also some of the vaccine. So in the context of the HIV prevention, actually, from the UNA's prevention reference group back in 2009, they have already defined the combination preventions. There are two key keywords. One is combination, meaning that's the use of a mixture of interventions, such as which can be grouped into biomedical, behavioural, and also the structural interventions. They should be composed of which constitute the right-based, evidence-informed, and community-owned programs. Another keyword is the prevention. So this mixture of the programs should have to achieve the greatest sustained impact in reducing new infection. However, in order to achieve the greatest impact, one should be these interventions should be prioritized to meet the current HIV prevention needs, tailored for the particular individuals and communities. That means one should know your epidemics. So what are our epidemics? So up to 2003, end of 2023, we have already 20,038 HIV reports received, and over 22,400 of them has already progressed to AIDS. So comparatively, Hong Kong has a relatively low prevalence of 0.1% amount HIV prevalence amongst the general population as compared with the global population of 0.7%. And we have the concentrated epidemics. As you can see, the prevalence is much higher amongst some of the priority population or the key population, notably as MSM, which have the 6.75% of HIV prevalence. So looking back for the past 4 decades, since 1984, when we have the first reported HIV cases in Hong Kong, the epidemics gradually grows and which rapidly rise. Which will rise until the turn of century, reaching the peak of 700 at 2015, and then gradually, upon the wide adoption of the test and treat strategy, and resulting in the effect of the treatment as prevention, the number of cases, HIV cases reported every year has decreased for the past 8 years, representing 45% drop. However, whether it's sustained, we are not quite sure. You can see that for these X consecutive years, the drop is only 2.9% in the last year. So the challenge is that whether we can sustain our effort to make the drop further. So let's look a bit closer look on our epidemics as maybe since what accountable for the drops. So in terms of basic demographics, the gender, you can see that the main drop is due to the male. In contrast, the female drop is more moderate. So if you compare with the peak in 2015, there is around 50% drop in the male cases, whereas the female cases only 30% drop. For the case of age, you can see that the main drop is concentrated around the relatively young population, ranging from those aged 20 to 49. However, for those greater than 50, there is, in contrast, a paradoxical increase. So our intervention should also tailor, apart from continue our efforts to concentrate to target to the young population, we also need to focus on the older population. Regarding the routes of transmission, all along over these 40 years, all along the route of transmission through the injecting drug use is relatively low level, you can see. But for the heterosexual, you can see that there is a quite flat in the past 2 to 3 decades. The number of cases is around 100 heterosexual cases reported each year. And for the MSM, you can see that it accounts for the majority of a drop. And so the drop is even more prominent among the MSM as compared with the overall drop. As mentioned by Dr. Bonnie Wong this morning, apart from the figures, we also need to have the composition of these HIV cases. One of the observations is that there are increased proportion of the late presenter. We can see from the slide, you can see that the proportion as manifested by those with newly reported case, when they newly first diagnosed of HIV, when their CD4 count is less than 200 cells per mil, which according to WHO is already fall into the definition of advanced HIV cases. So in the past 20 years, it's around half of these HIV cases belongs to the late presenter. And it's further improved and then followed by improvement until the 2014, 4 to 28%. But unluckily, it's in the past few years is quite bad. It's reverted to around half of them. Half of the newly diagnosed HIV cases are actually late presenter. Another way to look into late presenter is that look into the number of HIV AIDS cases reported. AIDS cases represent a very late stage of HIV infection without treatment. So you can see that in the last year we have around 100 AIDS cases reported, which is increased compared with the 2022. So you can also notice that in the preceding years there are quite a sharp drop in the number of AIDS cases. While the pattern, we need more time for observe to make a concrete conclusion for the underlying cause. Inevitably, the COVID impact is have this can be a very important contributing factor for this, which there may be the link in the affect the linkage to care and as well as the accessibility of HIV testing. So, just a reminder that vast majority of AIDS cases actually presented without HIV diagnosis before. That means that when they first have the HIV test is that when they already present with AIDS-defining illness. So this is room for improvement already. So for the low hour epidemics, it is still characterized by the concentrated HIV epidemic among MSM. And we have very good progress in decreasing the number of new infections, especially amongst the young MSM. But we have still some challenge in whether we can sustain our success in further decrease the number of HIV cases. And there are some issue of the late presenter. So back to sustain, back to our questions, how to sustain the further decrease, I think is the answer is the combination prevention. So the combination preventions is can be categorized into a very broad categories, the biomedical, which using the antivirals to reduce exposure, transmission, and infection. Examples including the treatment as prevention, preventing the MTCT, also some medications, antiviral in the context of pre-exposure and post-exposure prophylaxis. It also includes the behavioral behavioral approach, such to promote individual risk reduction, including the traditional condom use, uptake of HIV testing, to education, to social marketing, especially for the Youth Equals to program. Go beyond is the structural, is address the barriers, to minimize the barrier, eliminate stigmas, to promote an embrace environment. So in our local context, we have the recommended Hong Kong recommended strategy, which orchestrate a coordinated and consolidated response on local HIV control for the next 5 years. As mentioned by Dr. Ho, we have vision, the 3-0, and also we put much great emphasis on the HIV prevention, as well as the 95 treatment targets. So we would like to have 10 quantifiable targets to be achieved by 2026. Now is 2024. So let's see some of the progress. So the targets is well designed, which includes some of the biomedical indicators, including the treatment prevention, the 95, and also the prevention of the MTCT to achieve 0 new infection among locally born children. And for the biomedical measures such as pre-exposure and post-exposure prophylaxis, it is integrated into one of the indicators as the HIV combination prevention services accessibility. So, as mentioned before by various speakers, we have already, for the 95 treatment targets, thanks to the contribution of the Sandy Holt Center for Emerging Infectious Disease of Chinese University of Hong Kong, which construct the epidemic model using the Spectrum software. So we can see that at the year of 2020, we have a good achievement in the first 95 and also the third 95, but little bit not so good in the second 95. That means those on treatment, those among the diagnosed with HIV infection should be put on treatment. Only 84% of them are put on treatment. So for the progress, you can see that we have since 2012, we have good progress in reporting and on also the ART, but not the little progress in care. So the linkage of care, we should do more. For the pre-exposure prophylaxis, let me share with you our PRISM survey, which is an HIV and behavioral survey amongst the MSM and TG conducted in 2022. So among the sexually active MSM without a prior diagnosis of HIV, positive HIV diagnosis, 23% of them have ever used pre-exposure prophylaxis. In contrast to a similar survey conducted in 2017, only 3% of them have ever used PrEP. So for the current PrEP user as defined as the usage of pre-exposure prophylaxis within 1 year, it is 18.3%. So for the pattern of the usage, around 40% of them use the on-demand PrEP, which is the most common method of practice of the using PrEP. And for the source of PrEP, the online usage is the most common method. So let's go to the behavioral. Some of the indicators as highlighted red are concentrated on the condom use. Another one indicators is one of the targets is the uptake of testing as highlighted blue. So, but before looking into progress, I would like to highlight one of the policy brief last year issued in June last year, yes, concerning the counseling behavioral intervention. So actually, WHO summarized the 9 RCT to see the effectiveness of this counseling behavioral intervention, which with the primary or the sole aim to change behavior, whether the change of the institution of counseling to change behavior can actually change behavior, or even the incidence of SDI and something, and HIV. But they after the summary they have not shown that it is not shown to decrease the incidence and risk behavior. but this is not useless. But in contrast, if the counseling and information sharing, but not aimed to change the behavior, just you share the information, it is a very key of components to engage the priority population, but this should be carried out in a non-judgmental manner. And also WHO highlights that those counseling interventions that promote absentees and promote the conversion therapy are not recommended because it creates further barrier. So the implication for as a rapid event center and other service provider is that actually WHO is not against you to integrate the counseling for the behavioral intervention. In contrast, when you decide to include this component in your program, you should bear in mind the potential limitation and the cost. And also, the counseling intervention per se are variable, has some additional benefit. One is the engagement. Another is the develop rapport and building caring relationship between the service provider and the recipient. So the figures comes to figures. So the condom use, we compare the 2017 to 2022 figures in the condom use. You can see that there are drop in the percentage of condom use across different types of sexual partners among MSM. However, as you all know, PrEP usage is associated with decreased condom use. So for fair comparison, we have excluded, further analyzed after excluding the ever PrEP user. However, you can see that the drop is still exists according different types of sexual partners. So the condom programming should be continued and enhanced. How about the testing behavior? You can see that for the HIV testing, there are slight improvement. Around 50% of them have testing for HIV within 12 months. For the STI testing, there are prominent, very substantial improvement of HIV STI testing within 12 months. And I would like to take this opportunity to especially thank all of the NGOs, because where they perform the testing, actually 40% of these HIV testing are conducted and offered by NGOs. So you can see that this figure is thanks to the HS Fund to give us the figures. These are the number of voluntary testing and voluntary counseling and testing by NGOs as supported by the NGOs. You can see that in the around 2019, around 1,000 testing will performed every month. However, there is a significant drop over this 2020 to 2022, obviously due to the COVID. So I highlighted some of we call the local waves, the first, second, third, and fourth. You can see that every time there is a wave, there is a drop. And also the most traumatic wave is the fifth wave, which occurred in the first half of the 2022. So the first wave was a drop. But the NGO is very good. You can see that upon the resumption of normalcy, the testing volume is quickly climb up again. So to further enhance testing, our department has an initiative since last November. So everyone can, apart from the key population, everyone, you can order free testing kit from the websites. So we hope that this initiative can further decrease the barrier and enhance the testing. So taken together with the combination access to combination prevention, which is one of the quantifiable targets. So one of the quantifiable targets is that 90% of the key population, including MSM, should at least have 2 items of HIV prevention service. So for individual items, the accessibility within 1 year varies from 12% to 60%. And in combination, only 60% of the MSM has access to two more items in the last 1 year. So very far behind of the 90%, which we need to catch up. So for the behavioural, there are in the previous slide, I deliberately deemed some of them because this is not included in the quantifiable targets. However, this is no less important because it is already mentioned in the key strategic area, including the sexual education, HIV education, etc. For the structural, it is the stigma and discrimination reduction. It is also very important as mentioned in one of the key strategic area. So in the PRISM survey, we also touch on the discrimination, but due to time constraint, will not go into details, but just that the discrimination and stigma problem is still a very important issue affecting the sexual minority. So despite various campaigns and various workshops for the target to the healthcare professional, etc., we will continue our effort, yes. And also we have another initiative launched this year, the Commons, which is a one-stop service with providing comprehensive and holistic HIV prevention care services to MSM. So our colleague, Dr. Lisa Do, will have an introduction on them. So in summary, so there is no one major bullet of the HIV prevention intervention is not a single one can be sufficient to control the whole epidemic. So in other words, we have to combine it to achieve the greatest sustained impact. But beyond I think the combination prevention go beyond the combining the intervention. You should be combining our effort. So for the HIV prevention, we have many stakeholders, government and the non-government, etc. So we have to involve the whole society to have the concept, collective, organized effort for the HIV prevention and care. So as mentioned in one of the key strategic areas to mobilize the collaboration between the government and the wider society. So this is the last slide. So there is a Chinese saying, 48 畫. That means when one individual has arrived the age of 40, he or she should be certain, no doubt on the philosophy and the principle and all the identity of oneself. And take an analogy, we have 4 decades since the very first local the HIV reported case in our Hong Kong. This is 4 decades. So I think we have certain on several things. One is that the ending AIDS as a public health threat by 2030 is possible. This is not a slogan. We also know that there is no single prevention strategy sufficient to control the HIV epidemic. We also sure that the combination approach is the key, and also the collaboration, the combining all the effort to make the dream come true is also the key. So thanks for your attention. Thank you.